Okie doke. So welcome back today, 7/27. We are on week 9. We are right there on the cusp of being done. And I'm going to go over digestive today. But real quick, I want to revisit our schedule because when we talked last, we were finishing up urinary. We were going over some of the urinary pathophys. And I was going to treat digestive kind of the same, where we were going to do some normal run through today, just talk about like how food goes through the alimentary canal, maybe parts of the alimentary canal, like what makes up a gastric gland, and we'll still do that. And I was going to end up saving a lot of the pathophys for next week, which would have pushed the cancers down to next Thursday, and then the final exam would have basically been the very next day. And the more I thought about that, the less of a good idea that probably seemed, because it pushes the final Q&A back a little bit too far, I think. So what I've done, and you can't really see much difference here, is I basically got rid of the second digestive discussion. We're just going to peruse through the material today. I think it's written in a way that doesn't really take a lot of explanation. And since you've been with me for 9 weeks this summer, you kind of get the style of how I teach and how I go over things. So digestive isn't really, in my opinion, it's not that complicated. If you understand the basic run through, then the idea of the digestive system is this is the path it needs to take for the food and the accessory organs, like, where are we going to squirt it with this? Where are we going to squirt it with that? How do I get from point A to point Z? And if you understand that, then understanding pathophysiology to the digestive system is pretty easy, because usually you'll have an accessory organ that's broken, or one of the pathways is obstructed or not secured. So I'll go over that idea with you today, but I don't think it's going to take a whole second discussion just to revisit that idea. So we'll go through the majority of the PowerPoint today. I'm not going to read every slide to you, more or less just kind of a guide. And that way we're going to get that knocked out. Once we get done talking about the digestive system, which I really don't hopefully plan on taking too much of that, time today, I'm just going to kind of go over, again, what do we have coming up? What's the best way to go about doing that? So if you need any like last minute advice or a pep talk, let's start doing that today. So that way next week is just studying, just getting ready for the final. So the one thing I do want to say while I still have anybody's attention whatsoever is we really only have a week and a few days left. So just buckle down. Today would be a great day to get all your papers written if you haven't done those yet, or if you've only got 2 or 3 left, excellent, get it knocked out today. Again, hopefully I won't keep you too long today. You can use some of the time that we were going to use in class to write those papers. If you haven't started on any of the papers, get them all knocked out today. It's one of those things, once you get started and you do one of them, the rest of them are really easy. You can get them all done today and not have to worry about it again. So that's what I would do. Once you get done with writing the papers, then you can start focusing on just studying for the final. And since the final is going to be open note, you just need to organize yourself. So we'll kind of go over in a minute what's the best way to do that. And basically, you're just going to read through the PowerPoints, make note of some pages, stuff like that. So I'll go over that with you in just a jiffy. But next week, when we meet for Tuesday, I will cover like some basics of cancers and neoplasms, like how do we test for them, biopsies, what are we looking for, what are the top 10 different types of cancers, what are maybe some signs and symptoms we would see with some of those cancers. But then we'll also use this Zoom meeting right here as a Q&A. So if you are super on the ball, go ahead and finish looking over all the digestive, this weekend. So that way, when we do meet on Tuesday, you can ask any questions that I don't cover today. Because again, we're going to go through this a little bit quicker than I at first planned. I just don't feel like we should push digestive into next week. I think that'll give us less time to review the whole class in totality, because the final is going to be more comprehensive in nature. So try to get through all these materials, rewrite your notes for digestive. And then if you have any further questions about that, we can answer that Tuesday. And if you already are looking back at some of the material that you have questions over or don't quite comprehend just yet, use that Tuesday as well. So we can mostly do a little bit of cancers, a lot of Q&A on Tuesday, and then next Thursday will be all Q&A. So any questions that you have about any of the material whatsoever, obviously you would be pretty prepared by then because it's the day before the final. So again, with that being said, if you're just joining us a little bit late today, I just moved around the schedule just a little bit. I'm going to go over with you some digestive stuff today. I'm not going to get real deep into it, just kind of peruse through the slides, see if there's any questions I need to answer. And one of the first things I know I need to go over with you, because it's blank in the PowerPoints, is when we open this one up, the basic idea is given to you right here. We're tracing food through the digestive system. And I need to go over that with you. So in my class, we did this partially in the lecture. We did this partially in the lab. Like one of the whole goals of the lab was to be able to do this verbally. Like, and that's kind of the idea when you're learning the digestive system, is you want to in your mind and be able to see these things. At the same time, you want to verbally be able to describe what's happening to food as it's going through the digestive system. So that's what I'm going to cover with you right here. And then beyond that, what it does is it essentially shows you what could happen if, let's say, some of these sphincters were too narrow. Like if I have pyloric stenosis, for example, and we can't get food from the stomach to the small intestines, what would happen? So if we have obstructions to forward flow, or maybe if you have a sphincter that's leaky and doesn't seal, adequately, then you can have backflow. So that's some of the problems that we might end up seeing with the digestive system. You might have some type of obstruction. And again, it doesn't have to be a sphincter. Pyloric stenosis is an example of an obstruction, but you could also have polyps in the colon. And a colon polyp sometimes can get so big it can obstruct flow, and then you'll end up getting fecal bowel obstructions. And so there's different ways you can obstruct forward flow, but weakness in some type of sphincter could also lead to a backflow. So that's specifically what GERD is. Gastroesophageal reflux disease is essentially where your lower esophageal sphincter, or we sometimes call it cardiac sphincter, is not closing tight enough. So stuff is backing up. And, what would be a problem with that? Should be pretty easy to determine once you understand what's happening in the normal walkthrough. So we'll do this first. And I'll do that with you on some blank paper, and then we'll go back to the notes in a little bit. So this will probably take like 2 sheets of paper to go through if we're going to write out a lot of detail. But as you are familiar, our digestive system, so the GI tract, we sometimes call it, that's not coming in very clear, is it? Let's see. Why is that not coming in clear? Let's see, let me turn on another light, see if that helps. That doesn't help either. Is it not focusing on that light? Let me just write darker. See if it'll pick it up better. Technical difficulties. I mean, if we have to, I'll write like a little child with crayons and gigantic. So, that looks close enough. So when we're looking at the GI tract, all right, it gets quite a few different names. Like sometimes it's referred to as the gastroenteric tract, which weirdly, enteric actually starts with an E, but gastrointestinal is what that usually stands for. A lot of people call it gastroenteric. It's actually made up of a tube system, which we call the alimentary canal. And when we're tracing food through the GI tract, that's what we're kind of tracing. We're tracing all the steps that we would go through in the alimentary canal, from the mouth down the esophagus into the stomach, from the stomach to the small intestines. And then the small intestines is broken up into parts, like proximal to distal. You got duodenum, jejunum, ileum. Then we go into the colon, and the colon kind of goes up on one side, goes across, goes down on the other side. And all that's part of what's called the alimentary canal, which the food is in direct contact with. So when you end up talking about things like obstructions, like maybe a polyp or inability to seal off one area from another, like if the lower esophageal sphincter doesn't close adequately, then that's a problem with the alimentary canal itself, right? So that could lead to issues. And again, I know this isn't as focused as it normally gets. I don't know why it's not focusing automatically. There we go. That could be a problem. But you also have what's called accessory organs. And these accessory organs also kind of connect to the alimentary canal. So when you get into the accessory organs, for example, let's just say we have an esophagus right here. Here's my stomach. Stomach they usually call J-shaped because it kind of goes down, then it comes up. A very close by accessory organ that we sometimes run into is the pancreas right here. And the pancreas is considered an accessory organ because it's not actually part of this tubular system, but it does connect to it through some type of duct. And what that pancreas is going to do, so let's just pretend this is the pancreatic duct running through the pancreas. It's going to be providing digestive enzymes and bicarbonate ion, which will then use this duct to enter into the alimentary canal. So again, mouth, esophagus, stomach, that's all part of the alimentary canal. But then you have things like pancreas, you have stuff like a gallbladder. And the gallbladder is actually going to share that same duct with the pancreas. This is going to be sending in bile. This is going to be sending in digestive enzymes. But these two organs themselves aren't actually part of the alimentary canal. So they're considered accessory organs. So when you get into the accessory organs, they are usually providing some type of substance that's going to help us with digestion. Okay. So those are the parts that we talk about when we talk about the GI tract. It's kind of all that combined. And the ultimate goal of the GI tract is to be able to digest and absorb. And I know this is very elementary. It's basically to be able to digest and absorb foods. So a problem with either one of these can lead to issues, right? Like if I can't get bile into the digestive system, I'm not going to be able to digest fat adequately, right? But if I end up having inflammation of the small intestines or the colon, I might not be able to absorb it either, right? So you end up getting changes in your bowel movements, maybe we lose a lot of nutrients, maybe you have a lot of diarrhea, maybe that diarrhea is very mucousy and stuff like that. So again, you can have problems with both, right? So if I can't digest very well, that's an issue because I'll never be able to get the nutrients down to a small enough level to absorb. And then if my absorptive surface is damaged, it doesn't even matter if I digest it all the way because I can't get it into the blood. So that could be an issue too. So again, it's not rocket science. It's pretty straightforward. It's just sometimes, learning the basics, you have to remember there's a decent amount that goes into that. But that's why we've spent the better half of a year learning all this stuff, which is nowhere nearly adequate for learning anatomy and physiology. It usually takes about 4, 5, 6, 7, 8 years to learn, but you're getting it all in a year because you guys are special. So let's do a run through of the GI tract. Let's talk about how the digestive process usually works. And again, we can probably get this in maybe one page, but probably two. Let's start in the mouth. And as you know, digestion occurs through two main types of processes. You have mechanical digestion and you also have chemical digestion, which is mainly accomplished by enzymes, but bile and hydrochloric acid are chemicals that aren't necessarily enzymes. So that's what we're going to be writing down kind of to the side here is what type of digestion am I providing in these locations, right? And if there's somebody helping me, we'll write that down too. So in the mouth, we have two different types of digestion. We have mechanical digestion, which is going to be called mastication, which is chewing, right? And mastication is carried out by four muscles. This isn't going to be on our final exam, but if you ever get this on a standardized test, your four muscles of mastication, we can usually use the acronym TIME to remember: temporalis, internal pterygoid, masseter, external pterygoid. And these are controlled by cranial nerve 5, subset 3, right? So it looks like an 8, but it's actually the third part of trigeminal nerve, the mandibular division of trigeminal. So, you know, how could I reword that if I were a standardized test like a board exam? You know, I could say paralysis to which nerve could affect digestion, you know, and then they can give you some choices. So if I have a problem with my trigeminal nerve, probably have facial pain, most likely, like trigeminal neuralgia or tic douloureux. But you could also possibly have problems with your muscles and mastication. So when we do a neurological exam on a patient, sometimes we'll ask them to bite down like they're chewing food, and we'll see if that masseter muscle kicks out, right? So again, that's not super realistic, but that could be an easy example of how to turn something pretty straightforward into a more complicated standardized test question. But the mouth, they chew up food, right? And then we add our first digestive enzyme, which is called salivary amylase. And most of this is coming from your parotid gland, which is the largest of the salivary glands. But amylase is meant to break down amylose, which is a component of starch. So amylase is an enzyme that we use for carbohydrate breakdown or digestion, okay? So again, when you get into the basics of digestion, it's essentially, hold on, let me get into the basics of moving paper. There we go. So when you're doing digestion, we're trying to take the macromolecules like carbs, fats, and proteins, and we're trying to get them down to their basic building block or even smaller. So the basic building block of carbs is monosaccharides, and that's how far we need to take carbs before we can absorb them. So if I'm already in the monosaccharide level, that's great because it'll be easily absorbable, quick energy, right? But if it's in a starch level, it's going to take some work because starch is a polymer where you have like a glucose molecule, you know, a bond, another glucose molecule, or another single sugar monosaccharide molecule joined together. So it could be glucose plus galactose or glucose plus, you know, fructose, and then you'll have sucrose, and that's a disaccharide. That's too big. A single sugar molecule is the right size, monosaccharide. But starch is polymer, right? You know, so you get these long chains. So the idea of the digestive system is that I need to break these bonds, and we can do that mechanically or because I have to get it down to a small enough level where I can absorb it. Right? That's small enough to go through a cell, right? So the cell says, come on in, and then we can pass that eventually to a bloodstream or lymphatic system later, but that's too big. So we need to break bonds. With fats, you actually have to go further than the subunit. So monosaccharides is the basic building block of carbs, and that's as small as we need to go. Fats, the basic building block is triglycerides, but a triglyceride is actually still too big to be absorbed. So we actually even have to break that down into glycerol and fatty acids. All right, so you actually have to, I should have put fatty acids right here. That's what I meant to do with that other arrow, but you get the idea. So triglycerides, we need to break down to glycerol and fatty acids, then I can absorb that. And then proteins, we just want to take down to the amino acid level. Right? And we can absorb those. And similarly, when you get into proteins are usually very long chains of amino acids, and we need to break down all these peptide bonds to get the individual amino acid loose so we can absorb it. Right? So one of the first questions that a lot of times comes up with a digestive system is they might ask, what's the first digestive enzyme we introduce to food? Or where do we introduce the first digestive enzyme to food? So obviously in the mouth, salivary amylase. Amylase is an example of an enzyme. We can tell because it's got an ASE ending. Not all enzymes do, but if they do have that ending, it's a good indicator that it's an actual enzyme, not just a chemical. So if they ask you, what's the first digestive enzyme we add to food? Salivary amylase is your answer. But they could also ask, what's the first digestive enzyme we use for carbohydrate digestion? And still, salivary amylase would be your answer. But if they ask, where's the first digestive enzyme for protein added? That's not until later. We don't add any enzymes in the mouth for protein, or we would digest our own mouths. Your tongue's mostly protein, your cheeks are a lot of protein, so we don't want to do that. It would be bad news. Anywho. Next thing we're going to do is we're going to go down the esophagus. So I'm just going to let's put esophagus right here. I change this every time I write it out. I'm trying to think of better ways to write it. We're not going to stop in the esophagus, hopefully, unless you have some type of paralysis of peristalsis, in which you would have some pretty major dysphagia, right? Dysphagia is kind of like difficulty swallowing. So you're going to use peristalsis to go down the esophagus. So I'll just write that out. It's that kind of rhythmical contraction. Like if you're squeezing frosting out of a piping bag, you kind of constrict behind the frosting and you dilate in front of the frosting, so that's how peristalsis works. We have these circular smooth muscles, and when they contract behind the bolus, which is the ball of food. So if you have a lump of food inside of a tube, right, like this, then the muscles behind it will contract, they'll get smaller, the muscles in front will dilate, they get larger, so that'll push the food in a single direction. That's peristalsis. And that pattern of contraction and relaxation goes in a single direction. So that's why it's called rhythmical contraction of smooth muscles. But peristalsis is the main way we push substances through the GI tract. It's the main way we go from mouth to anus. But some people have problems with peristalsis of the esophagus, and so they get a lot of dysphagia. It feels like food's backing up. Once we get to, I'm going to put a star beside this, the lower esophageal sphincter, also known as the cardiac sphincter. I'll just put cardiac like that. That's the first kind of doorway we need to go through, because the next destination, of course, is going to be the stomach. And in the stomach, we're going to start doing some digestion again, but I have to pass through this opening first, right? So as we're going down the esophagus, so let's just put the esophagus right here. So again, here's the quick version, like a mouth, right? Esophagus. And as you're going down the esophagus, right, this bolus before it reaches the stomach, so let's just put the stomach right here, has to pass through this little opening right there, which usually stays closed until it's stimulated. And it'll be stimulated as the food approaches, right? Because again, as we're going through peristalsis, you'll have constriction of circular muscles behind the bolus, but you'll have dilation of muscles in front of the bolus. So as food's coming down the esophagus, once we hit that lower esophageal sphincter, it'll dilate, it'll open, and the food will just automatically enter. But once the food gets inside here, this lower esophageal sphincter or cardiac sphincter would seal shut. And the whole point of the lower esophageal sphincter is not necessarily preventing entry. It's more or less preventing backflow, right? Because inside the stomach, you do have a lot of hydrochloric acid, and the stomach is built to sustain itself with that hydrochloric acid because we have a very thick mucus lining, thanks to gastric glands. but the esophagus isn't nearly as well protected from acid, so we want to block that off. So that's the whole point of the lower esophageal sphincter. But if that sphincter is not working appropriately, then you can get GERD, which can lead to a lot of other problems. So again, we got to do the basic run through. And then once you understand the basic run through, all the problems become evident. So lower esophageal sphincter is what's going to allow me to go from the mouth down the esophagus and eventually into the stomach, right? And then it'll seal once the food has passed through. If it doesn't seal very, good, then we can have a problem like GERD. But once you're in the stomach, we're going to add some more chemicals and another enzyme, right? So once you're in the stomach, we're going to have some mucus, which is going to be added by mucus cells, obviously. You're going to have some hydrochloric acid, which is good in a couple of different ways. For digestive purposes, hydrochloric acid can help to denature protein, which basically just means to unwind it. So again, when you're dealing with proteins, you have an amino acid, peptide bond, amino acid, peptide bond, amino acid, peptide bond, amino acid. These can be very long sometimes. And so they just kind of get these very highly convoluted structures like alpha helices, beta pleated sheets, alpha helices, beta pleated sheets, and it just keeps getting all twisty and turning like this. So these proteins are very highly convoluted, right? And so one thing that'll help us digest this is to unwind it a little bit, right? And hydrochloric acid and heat can do that, even electricity. Right? So unwinding, it's the same thing saying denatured. So this is a denatured protein here, right? So if I want to go from this to this, you could add stuff like heat, like cooking it. You could add acid like vinegar, something like that. Obviously, hydrochloric acid is what we find in our stomach. Vinegar is different. It's acetic acid. But still, acid will do it. Citric acid, right? What's that? What's the seafood that you add like lime and lemon to or whatever? That's kind of similar. Ceviche, is that it? Ceviche? I can't remember. But yeah, it's kind of cooking it with the acid. So our stomach has a lot of acid already in it. It happens to be a very powerful acid. So that'll help to break down the protein, denature the protein. But we also are going to add another enzyme called pepsin. And we'll talk about the stomach later. So I'll put it like a double star here. And we'll talk about gastric glands in a little bit. So pepsin is an enzyme. This is an enzyme for protein digestion. Okay. So it'll help break down peptide bonds. Pepsin helps break down peptide bonds. So far, we've seen two enzymes. One enzyme we saw in the mouth, which was salivary amylase. This is good for carbohydrate digestion. So I'll just put carbs right here. And now we've seen pepsin in the stomach. Pepsin's good for proteins, but pepsin doesn't do anything to carbs. Pepsin's not really going to do anything for fats. So we don't really get very strong fat digestion until we get into the small intestines. I mean, you get a tiny little bit in the mouth, you get a tiny little bit in the stomach, but we don't even write it down because it's just not, it's not good enough. Right? So once we leave the stomach again, we're going to go through another sphincter, right? And that's going to be called the pyloric sphincter. And through the pyloric sphincter, I will then open up into the small intestines. So small intestines, so mouth, stomach, small intestines. And the small intestines, we can break down into three parts, right? You have the duodenum, the jejunum, and the ileum. So I'll just write that to the side right here. Because sometimes they like you to be able to do things, what's called proximal to distal. And when you're in the alimentary canal, proximal is going to be at the beginning, distal is going to be at the very end. So the rectum and the anus would be at the end. So if I'm going from proximal to distal in the small intestines, the duodenum's the one closest to the mouth, the ileum's the one closest to the rectum and the anus. So that's the order we go in. And when you're in the small intestines, we're going to have help from a lot of other places. Plus, you'll have intestinal enzymes too. Let me get this out of the way. So when you're in the small intestines, we will have help from two accessory organs, right? We're going to have help from the gallbladder. We're going to have help from the pancreas, right? And then the small intestines themselves also is going to be lined with enzymes. And the gallbladder, what it's going to do for me is provide bile. The pancreas is going to provide pancreatic enzymes and bicarbonate ion. And I'll explain that in a minute. And then the intestines themselves will have what's called intestinal enzymes. So we'll do a sidebar for this one in just a second. Okay. And then we'll kind of continue to our next page here. We'll do a sidebar for this one in just a second. But let's go ahead and get through the alimentary canal. So small intestines. Before we enter into the large intestines, we have to pass through something called an ileocecal valve. And the ileocecal valve is right near your appendix. I'm not going to write that down, but again, I can draw you a picture if you want me to in a minute. But the end of the ileum, right, that's the most distal part of the small intestines, and the cecum come together here. So the cecum is the first part of the large intestines. So once we pass through the ileocecal valve, we'll be leaving the small intestines, going into the large intestines, and the large intestines happens to also be called the colon, right? So we'll just put large intestines here. Or colon, right? And that's going to be our last portion of our alimentary canal, because that's what terminates as the rectum and the anus. And going from proximal to distal in the large intestines, you have cecum, you have ascending colon, and then as it goes up, it's going to bend at the liver, so we call that a hepatic flexure. So you have a cecum, right? Again, I can just draw it right here. So you have a cecum, which is kind of a large little beginning part. So if this is like my ileum coming in, here's my cecum. It's kind of an enlargement. You'll have like a little appendix right here. It actually goes over there, but I just didn't want to draw it too detailed. Here's the ascending part, right? Here's what's called a hepatic flexure right there. This right here is called transverse colon. So it ascends usually on the right side. Then you have what's called a descending colon. So cecum, ascending colon, transverse colon, right? This was ileum coming into that. So the distal part of the small intestines. This is all colon right here, large intestines. So cecum, ascending colon, transverse colon. This is what's called a hepatic flexure, because the liver is right here. This is called a splenic flexure, because your spleen's kind of right over here. This is descending colon, obviously. Anytime I've ever seen impaction, like impacted bowels, I always saw it right here, always right here. It's not, I mean, that's not the rule. It's definitely, it doesn't have to always occur right here, but this is where I always saw impacted bowels in the cadavers, right? And they could be very large impactions. So maybe a polyp developed right here, or maybe a person had surgery and there was scar tissue in there and it just didn't move very well. There's a lot of reasons why we can get impacted bowels, but it ends up forming a late bowel obstruction. And sometimes the feces would sit here and accumulate at this little bend right here, right? And you could get a very large obstruction in there, very large, extremely large. But descending colon's right here. And then it kind of forms an S-shaped loop. It goes backwards and back toward the middle. So that's called sigmoid colon. And sigmoid colon, they usually kind of combine that name. So there's the S-shaped loop right here. That's sigmoid colon with rectum. So sometimes they call it sigmorectal area, sigmorectal, but rectum is the last part that's descending. And at the bottom of the rectum, you have the anal canal, which I like to call the anal canal. Right? So that's the flow. Not a ton of digestion occurring in the large intestines. Some, like you'll get some vitamin and minerals absorbed there, thanks to friendly flora. Friendly flora kind of helps us break down some stuff that we might have missed. You'll also reabsorb, water and electrolytes. But again, there's not a whole heck of a lot of digestion like we're having back here. So I'm just kind of writing something different out there. This is mainly what the colon's known for, is reabsorbing water and electrolytes. But again, we do that in the small intestines too, to actually a greater degree. But again, what's useful about the colon, it helps us reabsorb water and electrolytes. So if I have a problem with my colon, you might end up getting feces that's too hard and dry because we didn't absorb enough water and electrolytes out of it, like mainly the water. Or you might end up getting feces that's too wet, like diarrhea. So if I end up having something that's causing food to travel through my colon too quickly, you'll get diarrhea. So any type of inflammation in here, maybe as a response to a food allergy or something like that, right? So again, that's useful information because, again, the transit time through the colon can determine whether we get a lot of constipation or diarrhea. But anywho, that's the basic run through. So we need to do a couple of things. We'll go back and we'll talk about what's happening here with the small intestines, but also wanted to go back and talk about some of the gastric glands that make the mucus, the hydrochloric acid, and the pepsin, because we also have intrinsic factor with there too. And that'll finish up our run through. Okay. So again, there's a decent amount to talk about with pancreatic enzymes as well. But so one of the things we wanted to go back and mention was gastric glands, which are part of the wall of the stomach. So like if this is my stomach right here, your stomach's kind of got these thick, like rolling internal compartments. And sometimes the visual appearance of that, we end up calling it rugae. But within the stomach itself, even at a microscopic level, you end up having these little pits or these little pores, right? So these little gastric pits or these little gastric pores will line the inner lining of the stomach. And attached to these gastric pits or pores are the gastric glands, which sometimes look something like this. And they're going to be lined by different types of cells, right? So this might have been something, if you took like a histology class, which I don't think y'all do, you might have seen that. But sometimes we talk about it in our class when we're talking about cells that make gastric juices, for example, are the 3 different types of cells that we find in the stomach. And it's not the only cells, but it's kind of the ones that are involved with digestion. So gastric glands, these things right here are going to be lined with 3 different types of cells. Like these cells up here are going to be mucus cells, right? And they're going to be contributing mucus to that gland, which will then be secreted out here, right? It'll be secreted out there. And the mucus cells always sit up at the top, right? So the mucus cells kind of sit right at the top because their secretion is going to come first. So in your gastric glands, you have mucus cells, which usually we just add like another O to it just to indicate that it's a cell producing mucus, and then drop the O, and then that's the substance, but there's no hard rule. But mucus cells obviously produce mucus, and the mucus itself is going to be a protective lining that's going to cover the inside of the stomach, right? So that's nice, and that's why the mucus cells always sit on the top of the gland up here, right? Because their secretion needs to come out first, right? So their secretion is going to come out first. Okay. And then lower down in the gland, I mean, this whole thing's surrounded by cells. Right? And each cell is contributing their own unique substance or substances. So some of the other cells that we have in here are things called oxyntic cells, also known as parietal cells. And these are going to be producing my hydrochloric acid plus something called intrinsic factor, which that's important. We'll talk about that in just a second. But again, we kind of noted what the hydrochloric acid does. The hydrochloric acid is going to help with protein digestion because it's going to denature proteins. It's not an enzyme, but it is a chemical. And another use of hydrochloric acid is it's going to make this environment inside of the stomach very inhospitable for bacteria, right? Unless the bacteria happens to love acid. So, but most bacteria doesn't. So hydrochloric acid can, maybe help mess up some of their enzymes, maybe even destroy some of the protein in the walls, right? So hydrochloric acid will help kind of get rid of some bacteria as well. But digestive purposes, it's meant to unwind the protein. So then when you have your chief cells, let's see, CH. So chief cells producing the pepsinogen, it'll help convert pepsinogen into pepsin, which is an active protein digesting enzyme. But what we actually produce in the cell itself, like if that's a chief cell right here, so if we got these cells lining the opening, so here's the opening right here, right? These cells, like these might be mucus cells, those are producing mucus to enter into the opening, and that mucus is all going to glob together. But if this is, say, a chief cell right here, then when it's producing the substance that's going to be secreted by it, so if this is a chief cell, right, then the substance it's secreting out is called pepsinogen. It's called pepsinogen, and it's going to be pepsinogen until it enters into the stomach, right? And once the pepsinogen comes in contact with hydrochloric acid, then it activates and becomes pepsin. But we can't activate it until it's in here, because we don't want pepsin floating around in the walls of the stomach. It would digest the stomach itself and you would get ulcers, right? We need it to convert into pepsin once it's in here, being surrounded by that mucus, right? So again, the mucus should come out first, lining the inner lining of the stomach, and then the pepsinogen can get converted into pepsin, and that's fine now because we have a mucus layer, right? But not until then. And the pepsinogen will be converted into pepsin by hydrochloric acid. And now we can use it as a protein digesting enzyme. But let's say we take a lot of NSAIDs, and NSAIDs can essentially be absorbed through the stomach. A lot of NSAIDs have acid as one of the ingredients, and so they end up being somewhat acid soluble. So those can dissolve through the stomach lining. And over time, that can actually wear a hole in the stomach lining. So as we kind of go through this little mucus layer, it can cause the mucus to kind of quit being produced, and the acid starts to erode this along with the pepsin, right? And so as the acid and the pepsin start to erode that, eventually you're going to get a hole in here that bleeds, right? And then that's a bleeding ulcer, which would be very painful, but you're also losing blood. And sometimes that ulcer can actually perforate all the way through. That's really bad. That's really, really bad, right? Perforated ulcer is going to create a gas pocket out here, and then you're going to have stomach acid and juice leaking out of your stomach and touching all the other stuff around it. So that's going to cause a big problem. But another reason NSAIDs can sometimes be problematic is not only are they sometimes acid soluble, but they can also stimulate sympathetic receptor sites. And sympathetic innervation, like if we look at sympathetics versus parasympathetics, sympathetics decreases GI secretions. It decreases GI motility, right? So if somebody's receiving some type of substance that can stimulate the sympathetic nervous system locally, then maybe they're not able to make mucus nearby, right? You ever take Adderall and you notice that your mouth gets real dry? Saliva is also a GI secretion, right? You ever taken some type of sympathetic stimulating drug and you have constipation? GI motility. I'm not going through the colon fast enough. So that explains why we see some of the symptoms or the side effects with certain drugs, right? If I'm taking something that's stimulating my sympathetic nervous system, that's going to decrease GI secretions, decrease GI motility. So I might have dry mouth. I'm going to end up having constipation. I may even have an increased chance of getting more ulcers, right? A lot of times ulcers we associate with NSAIDs because they can do that locally. They can inhibit sympathetic or stimulate sympathetic activity locally and inhibit mucus production. But the other reason we wanted to mention these three cells right here in the gastric pits or the gastric glands. So obviously one of the goals of the stomach is for protein digestion. And you're essentially just trying to change the nature of the food. Prior to getting into the stomach, it was kind of in a big chewed up ball of food called a bolus. And then once it sits in the stomach for a while, it turns into gravy, right? It turns into acidic chyme, basically vomit. Right. And as long as it goes this way, it's not called vomit. It's called chyme or acidic chyme. But if it comes back up this way, we call it vomit. So it's going to change it from a chewed up ball of food into more of a paste-like consistency. But protein digestion is a big goal of the stomach and changing the consistency so it can more easily transfer to the next thing. But also at the same time, because we're producing intrinsic factor, it helps with B12 absorption. So if something ends up happening to the stomach where the stomach is being destroyed, maybe some type of autoimmune disease or gastritis, or maybe if you have some type of gastric surgery to bypass the stomach, like a gastric sleeve surgery or a gastric bypass, then we might end up losing our ability to produce intrinsic factor. So when people get pernicious anemia is due to too little intrinsic factor, right? And so that could happen naturally with an autoimmune disease where basically you have antibodies that attack your parietal cells or oxyntic cells, and therefore you just can't produce any intrinsic factor anymore, right? Or I could have stomach damage, and the damage to the stomach itself hurt the parietal cells, and therefore I can't produce intrinsic factor. Or we sometimes will bypass the stomach through some type of gastric surgery for weight loss. And then again, you end up with pernicious anemia. But pernicious anemia is a decrease in intrinsic factor. Intrinsic factor helps to absorb B12. So the function of this is to absorb B12. And if I can't absorb B12, then that's going to decrease red blood cell maturation, which ultimately will decrease my number of usable red blood cells, which will give you the anemia. Again, it's not something you think about, but it can happen. So that was the stomach. Once we get past the stomach, you go into the small intestines, and the small intestines kind of starts up here. Like they say the stomach's J-shaped because stomachs can usually have 4 different types of shape, but they're all shaped like a J. So you can have like a really long J, a really short J, a really skinny J, a really fat J, whatever, it's still shaped like a J. So this upper portion right here, this is usually called your pylorus. This is called your fundus. This is called the cardia, and the rest of it's called the body. So you have a fundus right here, which is usable because we look at it on an X-ray, because there's usually a little kind of half moon gas pocket right here, which we can see on an X-ray. This is called the cardia, right? Where the word cardiac sphincter comes from. But it's also the same thing as saying lower esophageal sphincter, because this is our esophagus. Right? And esophagus does begin with an O technically, but we usually just drop it. So you can either call that the lower esophageal sphincter because it's the bottom of the esophagus, or you can call it the cardiac sphincter because the cardia is kind of this upper portion of the stomach right here. Here's the body of the stomach. This is the main part of the stomach, and then this is the pylorus. So your pylorus is what contains the pyloric sphincter right here. Okay. And that's what's going to allow food to transfer. Like this food's been sitting in the stomach, going from a bolus, like a big chunk of food. It's going to get ground up by the inner lining of your stomach, kind of like this. It's going to turn on that food, and little pieces will drop down into the hydrochloric acid, mucus, and pepsin, and it's going to break down into smaller little pieces. And so now it's essentially what's called acidic chyme, which is the consistency of vomit, right? And little by little, that acidic chyme is going to go through the pyloric sphincter right here and enter into the duodenum, which is the first part of the small intestines. So here's the first part of the small intestines. And we'll continue this picture on another page in just a second. But we have to be able to go from here through the pyloric sphincter into the duodenum to get there. So another thing that could end up happening is you could end up having something called pyloric stenosis, right? So with this one picture alone, we can sometimes see an issue that happens when you're going from one place in the alimentary canal to another. Usually we're going to separate some of these places by sphincters or valves. And if I have a faulty valve, like in the cardiac system, that's a problem, right? Similarly, faulty valves or sphincters in the GI tract. So with the lower esophageal sphincter, also known as cardiac sphincter, the problem it sometimes runs into is it a lot of times is too weak. And if you have a weak lower esophageal sphincter, then this substance right here can splash back into the esophagus and erode the walls of the esophagus. So if you start to get a bunch of acidic chyme splashing back into your esophagus, then it'll burn the walls right there. And then you get what's called GERD, gastroesophageal reflux disease, right? Which doesn't seem like a big deal, but GERD can eventually lead to something called Barrett's esophagus, where you've had some type of metaplasia, a cell change. And we'll talk about that next week when we do neoplasms. And then eventually that can lead to cancer. So heartburn causes cancer. Doesn't that suck? As if heartburn wasn't bad enough. But now you're like, well, crap, I'm going to get cancer too? Where's the Tums? Right? But unfortunately, Tums isn't very effective for curing the condition. It's just symptomatic treatment. So that's one thing everybody's heard of. Another thing that most people haven't heard of, unless you've had a child that's had to deal with this, is something called pyloric stenosis. And pyloric stenosis is usually one of the first types of bowel obstructions we end up seeing in some people. It's not the most common thing in the world, but stenosis means narrow, right? And so if I had spinal cord stenosis, that means the cavity within the vertebra is too narrow and it's squeezing my spinal cord, right? If I have some type of valve stenosis in the heart, that means the valve's not opening up very well. It's too thickened, right? So you can get stenosis in valves. Here, if the pyloric sphincter is too narrow, then food's going to have difficulty time emptying from the stomach into the small intestines. So what ends up happening when you have obstructions, and this is like one of the first types of obstructions that gets mentioned in the GI tract, is food has to exit some way, shape, form, or fashion, right? So if I can't get from the beginning to the end and go out the right direction, I'll just come back out the beginning, right? So a lot of times when you have obstructions, you're going to get a backup. And so this backup in this case is going to lead to a lot of vomiting. So this usually happens in children, like, newborns, and you're feeding them, you're giving them milk, and all of a sudden they just, within a few minutes, they throw the milk up again. And then you give them a different formula, and then they throw that up too. And then you try to give them something else, and they throw that up too. And every time you give them something they throw up, it's because they have an obstruction. Right? So body has to clear itself out some way. Right? So if I can't get this way, then I'm just going to go back up that way. So that happens with obstructions. A lot of times you'll get vomiting with obstructions. But once we go from, again, the stomach to the duodenum, duodenum starts right here, and then you got like jejunum and ileum. So duodenum is actually the shortest part of the small intestines. It only lasts about this far. You got like an ascending, another like transverse descending, and that's pretty much it. It's only a few inches long. But then you go into jejunum and ileum, and of course that's going to just keep circling around forever. So many feet of small intestines. But once we're entering from the stomach, so let's say this is our pyloric sphincter right here. And here's my duodenum right there. One of the first things that's going to happen is the food is passing from the stomach into the small intestines, is the contents within here is going to stimulate some of the cells that line the small intestines themselves in the duodenum. So I'll just put duodenum, right? Let's just say jejunum and ileum. So duodenum, jejunum, ileum. Once food starts to enter into that duodenum, the duodenum itself has cells that are sensitized to what's coming in. Some of the cells are sensitized to the acid that's coming in. Some of the cells are going to be sensitized to the content that's coming in, like carbs, fats, and proteins, right? And they can signal for help because they're going to need some help initially to get this food started digesting very quickly, right? So when you're in the small intestines is going to make up about 90% of all digestion and absorption. About all your digestion absorption, small intestines makes up about 90%. So very active, but it needs help to do that. So some of the help that's going to be coming into the small intestines is going to come from the pancreas, right? Some of the help is going to be coming from the gallbladder. So you got a pancreatic duct again that's going to open up to the small intestines right here. Here's your gallbladder. That's also going to open up to the small intestines right here in the same place. They kind of overlap each other. So that's where you ended up talking about that thing, the ampulla of Vader and the sphincter of Oddi, where these two things combine, right? And so what the pancreas is going to end up offering to the duodenum, so as the food goes from the stomach into the duodenum, the pancreas is going to send in digestive enzymes. So the pancreas sends in digestive enzymes. Very powerful digestive enzymes. And bicarbonate ion. And what the gallbladder is going to send into the duodenum is bile, right? So I'll just write bile. Of course, bile itself, right? Of course, bile itself is made in the liver. I don't know why I always capitalize liver. I just do. You don't have to, obviously. Bile is made in the liver, but it's stored in the gallbladder, right? And concentrated in the gallbladder. And the function of bile is to emulsify fat. So without bile, I'm going to have a really difficult time breaking down fat. So where the bile is actually coming from is the liver, right? So the liver, of course, sits right on top of the gallbladder, and entering into the gallbladder is something called a hepatic duct, right? So that's where the bile is coming from, going from the liver to the gallbladder. And from the gallbladder, it's going to go through a common bile duct down to this area to enter into the duodenum, right? So if there's an obstruction, say here, or if there's an obstruction here, or if there's an obstruction there, then bile can end up backing up. So if bile ends up backing up, it's going to get into the blood eventually, and then you can end up getting jaundice or icterus, right? So if it's backing up every time you eat food, it's probably an obstruction somewhere in here. So if every time you eat food, you feel pain under your right rib cage, like especially if it's real fried, fatty food, I feel pain under my rib cage, that usually means the obstruction somewhere like right here or right there. So you probably have some type of gallstone, or maybe you even have some type of gallbladder that's formed into a stone. So if every time you eat food, and especially fatty food, real fried food, you feel pain, then bile might not be getting in there. It's probably trying to squeeze bile in, squeeze bile in, squeeze bile in, but it's obstructed. That's a problem. So you'll get that pain, and eventually it could end up leading to a backup here, which could lead to jaundice. Or if you have some type of liver damage and the liver has become obstructed and I can't get bile into the system to begin with, then you'll get jaundice. So a lot of times if you end up seeing a patient that has icterus, which is a yellow sclera, that equals bad liver most of the time. If that's what you're noticing in the patient is they're old and they have icterus, there's probably something wrong with their liver. It's probably saying that there's something wrong here, right? Unless they're coming in with acute abdominal pain every time they eat, then it's probably a gallstone. But if you see icterus, first thing I would think of if I were you is a liver problem in an adult, right? Obviously, if it's in a child, then that's different. But icterus, jaundice is basically the same thing, just in different places. Jaundice is bile backed up into the skin, so they'll get this too. Icterus, you can see it in the eyes. So if you see somebody that's got really yellow eyes, they're probably alcoholics, right? Again, I'm throwing out commonalities, not judgment. Or they've taken a lot of medications, or they took a lot of medication real quick and it caused liver damage. So you could have acute liver failure in your teens and 20s. Somebody at Belmont Abbey had acute liver failure last year. But again, this could be an indicator of that. So that's bad news. It's no bueno. But again, that can come from an obstruction. So bile made in the liver, stored in the gallbladder, its job is to emulsify fat. So if I do get that bile in there, that bile is going to squirt the food as it passes by, and that's going to help the fat break down. Okay. But we're going to need more than that. And of course, we have other things entering other than just fat, right? You still have protein that's coming in. You still have carbohydrates that's coming in. So most of your real powerful digestive enzymes are coming from the pancreas. So pancreatic enzymes that are coming in here, those are the strongest enzymes that we have. So pancreas, again, is going to send two things into the small intestines. You're going to send in your pancreatic enzymes, which we'll list those out real quick. And you're going to send in bicarbonate ion. So bicarbonate ion, the usefulness of this is it can help buffer some of the acid. Because if I have too much acid coming in here without a buffer, it's going to erode the walls of the small intestines. So it's not going to feel very good. And again, you can get ulcers right here. So this is another place where ulcers can show up, right? Because your stomach, it's usually pretty well protected because it's got such a thick mucus lining. Once you get into the small intestines, not so good a mucus lining. Of course, there's mucus throughout because that helps keep things moving, right? But too much or too little mucus can be a problem, right? So if the acid starts eroding the walls of the duodenum, you can get another ulcer right there. So that's another site for ulcers. But usually the bicarbonate ion can help buffer that. So that's why we send bicarbonate ion. So as the acidic chyme, which is what we call the consistency and the nature of the digested material that's in here going into the small intestines. Once it gets in there, that acid irritates the walls of the duodenum. The cells in the duodenum start making secretin, which is an enzyme. I'm not an enzyme, I'm sorry, a hormone. Secretin's a hormone, and that'll tell the pancreas to send in bicarbonate ion. Okay. So bicarbonate ion helps buffer the acid. And then another thing that the pancreas responds to is another hormone. So secretin was a hormone made by the duodenum, but you also had cholecystokinin, or CCK. And CCK is going to be stimulated by the food content that's entering into the duodenum right here. So when food, like the presence of fats and proteins in particular, enter into the duodenum, then the cells of the duodenum are also going to produce something called cholecystokinin, or CCK, and that's going to stimulate the pancreas to send in its digestive enzymes, right? And it's going to squirt the food as it passes by. So as this food passes by, we're going to squirt it with bicarbonate ion, we're going to squirt it with digestive enzymes, and then it's going to keep going. And then more food's going to enter. We're going to squirt it with bicarbonate ion, we're going to squirt it with enzymes, and it's going to keep going. And at the same time, bile is going to be squirting it too, right? Because the gallbladder and the pancreas both respond to CCK simultaneously. So we're going to be squirting in bicarbonate ion, digestive enzymes, and bile all at the same time, as long as there's no obstruction. Okay. And as part of those pancreatic enzymes, this is important. We're going to have three that we list for protein. You have trypsin, chymotrypsin, and carboxypeptidase. Those are all for protein digestion. So trypsin, chymotrypsin, carboxypeptidase. You also have lipases, pancreatic lipase, and amylases. pancreatic amylase. Okay? This was also mentioned to you in the blood chapter in lab diet, right? And lipase itself is for lipid digestion. So these are all enzymes. So trypsin, chymotrypsin, carboxypeptidase, those are all for protein, right? And then, of course, lipase is for fats or lipids, and amylase is for carbs again. And they're very powerful enzymes. But what if something is preventing the pancreas from getting its contents into the small intestines, right? Maybe that stuff backs up. Or what if the pancreas itself has become damaged or inflamed? Then sometimes these enzymes will start to leak out. And the pancreas is one of the largest glands. It is the largest gland in the body, and it has a lot of blood that travels through it, right? Because not only is the pancreas an endocrine gland, it's also an exocrine gland. And so you have a lot of blood that's going through there, plus a duct. So if we start to end up seeing a bunch of lipase and amylase floating around in the blood, that might indicate that we have some type of pancreatic damage or pancreatitis, right? Which is no bueno, no bueno. If you have pancreatitis, that is a big freaking deal, right? So why might we get pancreatitis? Maybe you have really, really high fat floating around in the blood and the lipase just is attracted to it. Maybe we have some type of obstruction. Like you could have a bile duct obstruction that eventually obstructs the pancreas too, and it backs it up. You could have some type of pancreatic tumor going on. But if you start to get pancreatitis, what we're going to notice is the lipase and the amylase start to elevate in the blood, right? That's a good indicator that we have some type of inflammation or obstruction going on that's blocking the pancreas, right? So it's not good. Because if this stuff starts to leak out everywhere and it's getting into the blood, it's also going to start to dissolve surrounding tissues. So when people end up getting pancreatic cancer and pancreatitis, they can liquefy their entire abdominal content. Like they will turn into soup inside. Everything will get dissolved within their abdominal cavity. You can literally suck it out with a straw if you wanted to, because these things are going to be active, right? And they're going to start dissolving all the tissues around themselves. So it's not good to get pancreatitis. That's bad news bears. And that's why pancreatic cancer, once you get that, there's really nothing you can do about it. So bad news. But again, mouth, esophagus, stomach, from stomach to small intestines, from small intestines to large, right? Which is also the colon, 90% of our digestion and absorption are occurring in the small intestines. The majority of that is coming from those pancreatic enzymes, right? So you take the pancreatic enzymes, add the bile that you're getting from the gallbladder, plus intestinal enzymes. That's where most of your digestion is coming from. So these are going to be the more powerful enzymes. That's why it's dangerous if you get pancreatitis. That's going to help emulsify and break down fat. But you also have intestinal enzymes, which will also work on all three different macromolecules. So again, in the mouth, we didn't have enzymes for all three macromolecules. You just had a little bit of salivary amylase that helps work on carbs. In the stomach, we didn't have enzymes and digestive substances for all three macromolecules. You just had a little bit for protein. You had hydrochloric acid, which helps denature protein, and pepsin, which breaks peptide bonds. But once you get into the small intestines, now you're going to add the most powerful digestive enzymes, which are the pancreatic enzymes. And you have trypsin, chymotrypsin, and carboxypeptidase for protein. You have pancreatic lipase for fat, pancreatic amylase for carbs. And then you also end up lining the intestines themselves with intestinal enzymes. So you have intestinal lipase, right? You have sucrase, maltase, and lactase, which are good for breaking down disaccharides, carbs, right? And then you end up having the peptidases that can help, again, break down some of the dipeptides, right? So by the time you're done going through the small intestines, then yes, most of your digestion absorption have completed. So that is the normal run through. All that, hopefully, was just review. But it's a good review. It's a thorough review. And that leads into everything else. So once you understand the normal run through, everything else is easy. right? Because what if my lower esophageal sphincter is not working? Well, I could get acid reflux. Right? What's going to be signs and symptoms of acid reflux? Well, the heartburn itself, the burning sensation in the esophagus or chest, sour taste in the mouth. Globus, sometimes you'll feel like you're swallowing all the time, right? What makes it feel better? So let me go over a couple of these words, because this is really the first, I know we're at the end of the semester, but this is really the first PowerPoint where the main focus on all the rest of the slides are signs and symptoms, clinical terminology, and stuff like that. But the word palliative means what makes it feel better. Provocative mean what makes it feel worse. A sequela is something that we assume can happen because of this. It's like a sequel to, like sequelae of GERD could end up leading to what's called Barrett's esophagus and adenocarcinoma type of cancer, right? So sequelae are things that we predict could happen because of, say, GERD. So what's a sequela of GERD? Well, if it goes unchecked, you can end up getting Barrett's esophagus, which is essentially a permanent change. And Barrett's esophagus can then eventually lead to adenocarcinoma, which is a cancer change. So here's normal. After you have GERD for a long time, though, it might end up turning into this, which is called Barrett's esophagus. And then if you have Barrett's esophagus for a while, that can end up turning into this, which is cancer. So those would be sequelae in a sequence of events, right? What led to that? GERD. Isn't that crazy? Oh, sorry, I skipped down a couple slides. So there's GERD. Pyloric stenosis, we went over that one. So here's an example of a blockage. Pyloric stenosis usually occurs in children, right? So what are signs and symptoms? Frequent vomiting. Right? Every time you take something down, it can't go forward, so you have to get it back out so it comes back up the way it entered. Right? How do you diagnose it? Sometimes we're going to look at it on an x-ray, and if you swallow certain media, like there's certain drinks you can take that would show up very well on an x-ray, it can kind of show you how far the stuff's getting before it gets blocked up. So that's kind of useful. Barium x-rays are usually good for GI contrast. Ultrasound is good for movement. Like if you're seeing movement of blood through a vessel or movement of substances through, say, like the GI tract, ultrasound can do that. And then palpation, if you did pig dissection and you felt the pyloric sphincter when the small intestine started, you can feel that. So imagine if it's really, really, really thickened, you can actually feel a hard knot in the baby's belly. Right? So usually pyloric stenosis is something you would see in children. But the same rule will apply when you get into any other type of blockages, right? If I have a blockage somewhere, that means forward flow is going to be obstructed. So there's a picture later of where we're seeing some of these things. Look at that. Isn't that wild? So essentially the blockage is occurring in two places here. You got a blockage somewhere in here, here, right? And you're getting all this backup of gas. Sometimes when food sits in the digestive system for a long time and it can't move, then the bacteria will start producing gas and it starts to get all blown up. Here, the blockage is right here. Right here, there's a blockage right here. So that's a very late bowel obstruction, but the blockage is right there. That right there is crazy. Look at the size of these intestines. They're all swollen up. But bowels themselves have become dilated or swollen because of the blockage. It's wild. Hiatal hernia. This is about the only one that I haven't really gone over. It's a pretty easy concept. It talks about it here. But a hiatal hernia is talking about the idea of when I go from my mouth and the esophagus down into the stomach, of course, the diaphragm is right here. And as the esophagus is piercing through the diaphragm, we call that little opening right there an esophageal hiatus, right? So the esophagus actually has to pierce the diaphragm. This is the diaphragm through an opening called the esophageal hiatus. And then as soon as that happens, you get the stomach, right? So if I'm looking at an x-ray, usually you'll be able to tell where the stomach is because you'll be able to see a fundus. So obviously not those x-rays, but if I just do like some type of Google A to P, X-ray. AP just means anterior posterior. You could do P to A too if you're doing chest, like if you're looking at the lungs. Usually you try to put the object that you're looking at closest to the bucky. Let's see. Let's just say A to P. Here we go. Here's a fundus right there. So there's a fundus. Here's your diaphragm right here. You can't really see it other than the outline. So here's diaphragm, and you're just assuming where it's going after this. Kind of drops down. Here's the diaphragm right there. So there's diaphragm. Here's the stomach. So the stomach, what I'm trying to show you is the stomach is right beneath the diaphragm, and it is right underneath it. So here's the fundus right there. It's the fundus. Here's another one. So here's your diaphragm right here. It's higher on this side because of the liver, and it drops down. Here's the diaphragm right here. Right? Here's the fundus. So the stomach, what I'm trying to show you, is right beneath the diaphragm, right? So you can usually see that little fundus on the x-ray. It's a little dark, little half moon. And sometimes if we have too much pressure in here, maybe because you bend over too much, like you're always bending over working, like you're leaning over the desk and you're working down here all the time, or you have a tight belt, you know, like your belt's too tight. So here's a belt. If the belt's too tight, that can push back, and you can actually end up pushing this part of the stomach up through that esophageal hiatus, and it gets trapped up here. So you actually get a portion of the stomach up here, and that'll actually cause the lower esophageal sphincter to open up a little bit, and food content comes up. So you have this sense of indigestion all the time and heartburn because the sphincter is not closing very well, and probably, you know, some mild discomfort because of that. But hiatal hernia is where the actual stomach itself starts to poke up through that opening, esophageal hiatus. And a lot of times it can go back. Stretching sometimes helps, stretching across a ball, but you also have to remove whatever caused it to begin with. You know, quit bending over so much, don't wear tight belts and stuff. But the rest of the PowerPoint, again, it's pretty straightforward. Like there's different things that are going to cause obstructions, like gallstones, and you're going to get a backup of something, right? So if I have gallstones, then I'm going to have bile backing up, right? Or I could end up having mucus, cystic fibrosis. You know, mucus is a useful thing in the digestive system, obviously, but if we have too much, mucus is very useful in lots of parts of the body. It's very useful in the respiratory tract because it can help capture particulate matter, right? And we can remove that mucus along with particulate matter very easily. It's also very useful in the digestive tract because it helps to lubricate the stomach. It helps to lubricate all the, you know, the esophagus, your mouth, everything that has food transferring through it is useful to have mucus because it's going to add ease of transport, right? Things will slide along. But if I overproduce mucus in the lungs, that's a problem because it's going to start obstructing airways, right? And if I overproduce mucus in the digestive system, it can end up clogging up a opening. So what are some of the small openings that we talked about that mucus could clog up? Possibly, if here's my stomach right here, and here's a common bile duct coming in. Here's a pancreas. Pancreas actually goes more like this. And here's that pancreatic duct coming in like this. Mucus can actually block this pancreatic duct too, right? So guess what's not going to get into the duodenum, right? Eventually, if I have mucus from cystic fibrosis blocking my pancreatic duct and I can't get in here, then I'm going to lose most of my digestive enzymes. So how am I going to digest protein? How am I going to digest carbs? How am I going to digest fats, right? If I can't get the stuff in here. And if the blockage is right here, now I can't get in pancreatic enzymes or bile. So I'm really going to have a hard time digesting fats, right? So if I can't digest fats, not only am I losing fat, it's going to be coming out of the digestive system. So it should be noticeable in the stool, but I'm also losing some of my fat-soluble vitamins as well. Right? So vitamins A, D, E, and K, right? And if I can't digest proteins, that's a problem, right? If I can't digest carbs, that's a problem. right? So a little obstruction can cause a big deal depending on where the obstruction is. So if I end up having cystic fibrosis or some type of obstruction that's blocking the gallbladder and the pancreas from getting in here, then this stuff will back up, right? And that can cause issues. So that's how the PowerPoint carries on. It just talks about all these different problems we can have, most of them being things like obstructions, right? But it also talks about inflammation too. Like if we just have general inflammation, like Crohn's, you sometimes will end up seeing general inflammation of maybe the stomach, which is called gastritis, or most of the time the colon, which we can call colitis. So Crohn's, ulcerative colitis, IBS, they all look similar to each other, signs and symptoms wise, when you get into the GI portion of it. But obviously with Crohn's, you might also have a skin rash along with IBS. So that's going to differentiate it that it's not probably just IBS, it's something more. So Crohn's, you'll probably have the facial rash, sometimes called the butterfly rash, the malar rash, right? Sometimes associated with that because it can be similar to lupus in a way, right? But most of this ends up staying in the GI tract. Lupus, you'll definitely have that rash, right? So it's literally called a lupoid rash or a lupin rash in lupus. But, you know, Crohn's tends to stay more in the digestive system, even though it's autoimmune. Lupus spreads all over the place. So you would absolutely have a rash on the skin, absolutely have a rash on the face, absolutely have IBS and ulcerative colitis. So these kind of all go together, but you just want to differentiate one from the other. So Crohn's is going to tend to stay in the colon, creating IBS. So we want to eliminate other causes of IBS, like just stress in general, right? You might end up wanting to do like some type of look inside the colon. Lupus, think about you have skin problems, plus you have all these other problems. Right? The whole reason lupus is called lupus is because of the rash. So lupine rash. Let's say it's basically the rash that looks like a wolf face. So if I'm presenting with IBS plus this, then think lupus, right? And they call that a lupine rash because, again, it looks like a wolf. I always tell people I don't see it, but wolf face. So you see that coloring that spreads out like that. And so here, kind of similar. So again, I don't see it, but I mean, I get where they're going with it. So you've got that rash that goes across the nose and spreads back out again. So if you, again, we're just using context clues a lot of times. We're using a combination of things. We're using some type of physical exam where we're observing what's going on with the patient. We can use stethoscopes, we can palpate, we can percuss, we can just look at them, we can, just get any information we can with the naked eye. That's part of the physical exam. We're going to use imaging sometimes with patients, and then you're going to use labs. So if I have lupus, physical exam, I see a malar or a lupine rash. On the presentation, why did the patient present? Well, they had some type of, colitis-like symptoms or irritable bowel-like symptoms. On imaging, what might I see, right? So we're just putting as much information together as we can to come up with some type of differential diagnosis. So a lot of times on differential diagnosis, these might all come up. But what would eliminate one from another? Well, is it just coming with stress? Then it's probably irritable bowel syndrome. Is it happening randomly, right? And we have a skin rash, then let's throw in lupus, right? But it'll go through and kind of talk about each individual one. Sometimes when it shows up, it's going to be different. But again, it's just trying to help you differential diagnose. But a lot of times you don't really necessarily need to know the diagnosis. Like if I have IBS versus Crohn's versus ulcerative colitis, it's going to be the same treatment regardless. So it's not all telling, but again, it should make sense of why we're seeing the things that we do. So if we have inflammation, we might have some absorptive issues, obviously pain, and depending on what gets inflamed, we'll have different symptoms. So if I have gastritis, I'm probably not going to see an increase of amylase and lipase in the blood, right? Because that would indicate that we have a problem with the pancreas, because where does pancreatic amylase and pancreatic lipase come from? The pancreas. So gastritis isn't going to present with that. Hepatitis isn't going to present with that. But if I have pancreatitis, it should have increase of amylase and lipase in the blood, right? If I have gastritis, I'm probably not going to have AST and ALT elevated in the blood. I'm probably not going to have amylase and lipase elevated in the blood, but maybe I would end up having some type of problem with protein digestion. Maybe I would have some type of, obviously, pain in the stomach. Maybe I would have a sense of indigestion that we don't get with the others, right? So the enzymes aren't going to be elevated in the blood, but we're going to have some type of gastric distress, right? Maybe if it gets inflamed enough, it'll cause ulceration. So we might end up seeing vomit, right? Or maybe if it's bleeding in the stomach and we're not vomiting up, it's coming out of the rectum, then it ends up being a black tarry stool because the blood itself got digested. And when blood gets digested, it turns very black, right? And sticky. So again, it's not a hard read. It's not a hard read. But once you get to the very end of some of the conditions, right? So ulcers, pernicious anemia, it does do a quick review of GI hormones. It switches gears, it gets into the liver. And as a whole, the liver has certain functions that it needs to do. So when I think about functions of the liver, without looking at this page here, I tend to think about liver functions, again, make bile. It's going to be pretty good for immune function because we're receiving a lot of we're getting a lot of venous drainage from the digestive system into the liver just to make sure it's clean before we send it into the blood. So a lot of your digestive system, they end up attaching to veins that go to the liver first. And so we call that the portal vein, right? The hepatic portal system, right? So the portal vein or the hepatic portal system is draining the digestive system, and then that will get sent back into regular venous flow. So we want to make sure that stuff's clean first. So we do offer a lot of immunity around that area, right? Believe it or not, there's a big part of your immune system that lives right around your liver, right? Right around your hepatic portal system, right? So that term that I'm using, I have added for you here, right there. It's on the very next page, sorry, right there. And so there's a lot of immunity that takes place there to make sure that foodborne illnesses don't make it past the digestive system, right? That would be very bad. But it also ends up talking about, well, what if this gets blocked up in a minute? So I'll mention that too. But just basic functions of the liver: make bile, provides immunity, detoxification, right? It detoxifies things like alcohol. It detoxifies certain drugs. It'll change, certain chemicals to other chemicals. So that's sometimes part of the detoxifying process. We can change it from one harmful chemical to a less harmful chemical, but we can also change one useful thing to another useful thing too. Like when you get into energy for the body, sometimes we need to convert fat into sugar. Sometimes we'll convert sugar into fat. Sometimes we're going to convert protein into sugar, and the liver can do that too. So it can change one chemical to another. So it's like a chemical factory. It's a detoxification system. It provides a lot of immunity. A lot of blood flow ends up going through the liver, plus we make bile. So if I end up getting damage to the liver, like hepatitis, that's a big deal, right? Because we can have a blockage and the bile gets backed up. So a lot of times when we see hepatitis, we might end up seeing jaundice because of that, right? Icterus. That's bad news. Plus, we're not going to be able to detoxify stuff anymore. So things that stayed or things that went into the body stay longer. So that's going to affect how we metabolize drugs, for example. So it might end up changing how often a patient can receive drugs, or how many drugs do you want to throw at a patient, right? Because maybe the hepatitis itself came from drugs, like a drug overdose, and that could be prescription or, right, illicit. Right? Maybe they were just taking really strong antibiotics and that gave them hepatitis, right? So we want to be careful how many drugs we give them to treat the problem. But, if I have an inflammation, maybe steroids will help. But certainly wouldn't want to give them a bunch of NSAIDs after that, right? That's not going to be good. It's just going to tax the liver even more. But obviously, we're going to have a hard time fighting off infection as well. And then if you have some type of swollen liver, you might also get a backup of the portal venous drainage, right? So the hepatic portal vein, think about that as the all-receiving vein that's coming from all the digestive system through the liver first. Just imagine if that gets backed up. Where's that going to back up into? The entire digestive system, right? So you might end up seeing a swollen abdomen because of that. And then you're also going to start to get blood backed up in the esophagus too, because the esophagus is part of the digestive system. So that drains into the hepatic portal system. So you can end up getting these things called esophageal varices. And esophageal varices is basically like varicose veins of the esophagus. And here you can actually see this one's bleeding, right? So this person's probably going to vomit up blood quite a bit. But again, it's not a hard read. A lot of these terms I'm sure you're familiar with, like cirrhosis of the liver. This is usually fatty scar tissue that develops from long-term alcoholism most of the time, right? Long-term drug use. But a lot of times what we're seeing more of nowadays is non-alcohol related fatty liver disease. So a lot of times liver damage, hepatitis, they usually do come in alcoholics, right? So a lot of alcohol related liver disease, but we're also getting, food caused, maybe too many fried foods over a lifetime, just poor eating habits in general. And people are getting non-alcoholic fatty liver disease where they're showing the same signs and symptoms, just minus the alcoholism. But anywho, that is the digestive system. Once you understand the normal run through, everything else becomes easy because we're either having some type of doorway that's not opening. We have some type of tube that's not open enough. Maybe the doorway's too loose and allowing stuff to go back. That can end up creating a lot of problems. And depending on where the blockage is, the problems can become mild to major, right? So it's not a difficult read. Let me see, was there anything else I was going to mention to y'all today? Let me look. So what I just covered, and again, if you join me a little bit later, the digestive system, I was just going to go over the basics today, talk about all the pathophysiology next week. But again, that's going to push us a little bit too close to the end. So I went over the basics today when we did our run through. And then I just talked about the premise of, well, now that we know that the basic run through can get obstructed, or we can have some type of faulty valve, or we can have some type of inflammation of, then that's going to lead to most of our conditions. And if you know what the basic functions of each part does, then the results seem pretty straightforward. Like if I have inflammation of the pancreas, what can end up happening, right? If I have inflammation of, say, the gallbladder, we sometimes call that cholecystitis, what could happen? Why did we get that? So with that being said, what we're going to do next week is we're going to go over any questions that you have about the digestive system or in general. At the very beginning of class next week, I will kind of go over cancers and neoplasms, the basic idea of why cancers form the way they do, treatments, stuff like that, top 10 cancers. We're not going to spend a whole heck of a lot of time on it. And then next Thursday, we're going to use that just strictly as a Q&A. So we can do Q&A a little bit on Tuesday next week. So if you have any questions about the last few chapters, we can go over that. And then Thursday, we'll save that as just a Q&A day because we kind of need to have all the questions answered, hopefully by then. In preparation for your final lecture exam, here's what I would do today, if I were you, just to get started. Do the papers first, get those out of the way. If you are strapped thinking of ideas about what to do for your papers, do diabetes type 1, there's one paper. Do diabetes type 2, there's another paper. And then just pick a disease from each system if you want to. Like you can pick a neurological disease, pick a blood disease like leukemia. You could pick type of cancer too that we don't mention in the PowerPoint. There's a gazillion of those you could do. You could talk about some of the things that we briefly mentioned, but didn't get real deep into. You can talk about different types of renal failure if you want to, but just kind of pick and choose ones from different organ systems if you are running out of ideas. Or if you know what you're going to go into, try to pick things that are all related to what you're going to see in the future. Again, I don't care. Format, all I need to see is that you have what I listed for you to put in there. So let me show it to you real quick. So for your papers, again, 10.5 pages that deals with what's part of the paper. It's a little bit slow. Or let's see. No. Sorry. It's not on the announcement. It's on the syllabus page, right? Let's see here. Sorry about that. Let me take this and I'm going to copy it. And I'm going to add it to our last module, okay? So that way it's all in one place. So papers due, edit, what? Papers, huh? What papers to have. There we go, paste. So if you're thinking what papers, the 10 total papers that are due by the end of the semester, what needs to be on them? The following things. Just pick why you chose the disease. Again, it can just be I chose this at random because I had to, or I'm choosing this because I am going into oncology and I just wanted to do cancers. Put the disease name, any AKAs. Right? So again, some diseases have a common name. Sometimes they're called by their formal name, like for example, mononucleosis is sometimes called mono, sometimes it's called infectious mono, depending on how severe it is. Sometimes they call it Epstein-Barr virus by what causes it. That's fine. When you get into, trying to think of some of the other ones. Like if you're talking about human parvovirus, B19, they sometimes call that fifth disease, right? So some diseases have common names. Sometimes they'll have less common names. Sometimes they use AKAs. Make sure you put those in there because again, that's a good way to study for boards. They'll call it fifth disease instead of parvo, right? That's just what they'll do. So why you chose the disease, what diseases are you doing it on? What are the basic signs and symptoms? What test would you run to diagnose this disease? Is there anything pathognomonic for the condition? Those are always good to look for because that'll help you identify it in the future. Most diseases don't have something that's pathognomonic, right? If they did, then they would be easy to diagnose. But some diseases, there's a certain thing we look for, and if it's there, then it's this disease for sure. That means it's pathognomonic. What's the prognosis? Prognosis is what's going to happen. You know, what's coming up. Are they going to live? Are they going to die? 5 years, 10 years, you know, they should recover to full health as long as they're treated for the infection. What, you know, what's going to happen? That's prognosis. What's the treatment? All right. So if the prognosis is bad, they're going to die, then probably the treatment's all going to be palliative, right? We're just treating for pain and comfort. If the prognosis is good, we can cure this. How? Is it antibiotics, steroids for inflammation? What do we do? So treatment usually depends on prognosis. And if drugs and medications are the primary treatment, you know, what are some possible consequences and side effects? So that should be very easy to make a 2-page paper out of, right? So again, 10 pages or 10 papers, about 2 pages a piece. Easy peasy. I don't care about format when it comes to like APA or MLA or anything like that. Just write the paper out, put where you got your information from. So just cite your source or sources and you're done, right? So format, I don't care. Try to get them done today though. So I know that seems like it's asking a lot, but you get it out of your way, you'll feel so much better. And once you do one, the rest of them are easy. So you don't have to do diabetes. You don't have to do diabetes type 2. And of course, I'm talking about diabetes mellitus here, but if you're running out of ideas for things to do on your papers, absolutely throw those in there because that'll help you in life because you'll see that all the time. You'll see diabetes in every age, every, across the board. You're going to see diabetes a lot. So you might as well know more about it. Once you get done with your papers, just send them to me all as one big file. So you can attach 10 papers to one email and send it to me. So email when you're done. You can put them end to end if you want to. You can say, I'm going to do Huntington's disease as one paper, and I'm going to describe it. And then you can just space. And then I'm going to talk about Parkinson's disease, and I'm going to describe it. You can do it all as one big file if you want to. I don't care. It can all be one paper with 10 different diseases, but email it to me, 10 separate diseases, all one big file, whatever. Whenever you get done, I'll put the grade in as pass, fail. So you'll either get all the points or part of the points or none of the points. Depends on how many you do. Once you get done with the paper, so get this checked off first, then go ahead and start studying for the final. So how am I going to study for the final? Here's what I would do personally. Look over your GI stuff first, because that's the newest stuff. Go ahead and look over cancers and neoplasms, write whatever notes you want to do with that. Once you get done rewriting notes for these, it'll take a day or two. So let's say Saturday, Sunday. So if you're doing your papers today, maybe today and tomorrow, review this, Saturday, Sunday. What I would do is I would go all the way back to the beginning, and I would start doing page citations per disease. Every time you see a disease in your previous PowerPoints, note what page they're on and just put it on a big sheet. Just get you a sheet like this and say neuro, and just say one, like let's say Parkinson's was on slide 32, right? Huntington's chorea, slide 33, something like that. I mean, I'm just making that up. I don't know which slides anything's on, but go all through your neuro, mark your diseases, put what slide they're on, because a lot of the final is going to be about diseases. Not every question is going to be about a disease, but a lot of it is. Okay. Go through every chapter, like fluids and electrolytes. Obviously, you do with neuro. That's the first thing I thought of. Cardio. If we're talking about certain diseases, left side of heart failure, right side of heart failure. Where do we find these things in the notes if they're in there? But that's what I would start doing. And that way, when you take your final lecture exam again is going to be open note, right? So this way you can go back and find it, which is fine. Again, we're trying to accumulate as much information as we can in this class. This class is a stopgap, is what it is. A stopgap means this is what we're using until something better is in place, because we just need it to get this information to you. So that's what I'm trying to do. I'm trying to get as much information to you as possible. Anything you get from this class is gravy, right? It's beneficial, because at first we were just going to have anatomy 1 and anatomy 2, and there's really not enough time to go over a lot of pathophys there. And it's really a hard task to ask you to understand cardiophys, renin-angiotensin aldosterone system in 2 semesters, along with all the neuro and everything else. So this class was meant to review a lot of the basics, and then add any pathophys that we could possibly handle. So for the final exam, there's going to be a decent number of questions from the pathophys. Go through your notes, start to find where those were in the notes, if any, and just get organized. So today, what I would do if I were you, today, papers. Every day from that, afterward, organize. Be familiar where stuff is. That's what I would do. But I will let you go for today so you can go brew a pot of coffee or something. Again, next week, Zoom meeting Tuesday, I'll go a little bit over cancers and neoplasms, and I'll take any questions. Next Thursday, we're just going to do Q&A. So every time you go and you find something and you have a question, you can email me as well anytime, and I'll answer it for you, or just bring it with you next week. But before we meet next week, get as much studying as you can, get the papers done, get organized, and then it'll make next week much, much easier for you. But have a good rest of the day.